Hello. Hi, Stacy.
Hi. How comes you can't see me?
Did you hit share my screen? Or share?
You were able to see my screen the other day.
Yeah, I don't know.
Oh.
Hi guys. Sylvia.
Here it is, share screen. There it is.
Sylvia.
There.
Sylvia, Jessica. No, you're sharing your screen. You don't want to share your screen.
Oh, I thought you said I did need to share my screen.
No, I meant share your camera.
Now what did I do?
Just hit stop sharing.
Stop share. There it is. Okay.
There you go.
Okay. But you still can't see me, so that didn't help that part. Integrated webcam is checked.
On my end, there's a line through your webcam.
Integrate, select the camera. Video setting, choose virtual background. No. It's worked the other day and I didn't do any changes. Enable HD. I don't know.
Are you eating Gushers?
Yes. Oh my God, I love Gushers.
Video. I don't know.
Maybe if you go out and come back in.
Yeah, try that.
I'll try it, guys.
Okay.
Back.
Sounds like a wizard. I'll wait for her to come back in. Then I'm gonna go let my dogs out real quick. And then I put my two older dogs, I just locked them away because my pup, she'll get them all barking.
Yeah, it worked.
You got it. All right. Oops. Unmute. I will be right back. I'm gonna let my dogs out. We got what, 5 minutes. Let my dogs out and then
I'm watching my video anyway.
it's recording and I'm gonna share it.
I was watching the other video that you wanted us to watch.
Oh, you're watching it. Okay. I didn't finish that little quiz, so you're all good yet.
All right.
I've been getting, today my day was just addressing emails.
I believe it.
Oh my God.
Now you're keeping up.
Barely. I haven't done any work in my doctoral class this whole week yet, and that's on my list of things to do is get myself back in that mode, but it takes up so much time to create clinical assignments. All right, let me go take care of these dogs so they're good.
Sounds good. Jess, can you hear me?
I hear you.
I don't think that she put the Alice training stuff up yet. We saw there was a Dropbox today, but I don't think.
Yeah, I see the Dropbox. I think Carol said she did it already. I thought someone said they did it already.
No, they said you can do it early. Ivana, I think, said you could do it early.
I hope she puts it up early.
I hope for this lecture, she doesn't share us to her screen only, because if she does, then I'm going to have to take notes on my phone.
Oh.
I don't know, maybe I can figure out some kind of way to do this.
You print out the PowerPoints.
Not now, she can't.
With a split screen type of thing.
Yeah, I can always send you pictures of what I write down too.
No, I think I can do it I have it split screen.
This is like whack. Every time someone speaks, they get bigger on my screen.
Stop, I don't like that.
That's weird,
Yeah,
right?
mine too.
You can change it.
That's crazy.
The top corner says speaker view, and then you can press it. It's the boxes, and then it presses gallery view, so you can see everyone.
Oh, what do you want me on? Gallery view or not gallery view?
Gallery view.
Oh, hold on. Gallery view. Okay. Oh, there you all are.
Yeah.
Hi, everyone. I see Stacy now. I didn't see you before.
Guys, look how prepared I am. How do I switch my screen to? I don't have a camera back there. I'll just show you. Look how prepared I am.
Let's see. Let's see. Girl, get it. Oh, yeah.
Is that beer?
Yeah, it is.
Drink some for me.
I've had that for like months. I'll never finish it.
I miss wine.
Oh, yeah, Jess, I forgot. Sorry. Can you imagine going through this without me? Oh, no, you can. I'm sorry. Fun. Thing off my screen. The sun will go away soon, but
Oh my god, so I messaged Ina and I was like, oh, just want to like make sure you're like doing okay, blah blah blah. Like, thank you for posting the recorded lectures because it really helped me for like studying. And she goes,
I listened to it again.
huh?
I said I listened to her stuff to study, to hear it verbally.
Yeah, so I just like emailed her saying, thank you. And then she emailed back, she said, I had a chuckle when you had to call for your calculator. I was like, oh my God.
I had to use my phone. I didn't have a calculator at all.
See, I was afraid.
I was going to use my phone and I showed it, and I showed me going into the calculator, and then I did it, and I showed her my answer. Were we supposed to split that by 2, or was it 13 by 2?
We were, I got it wrong.
Split it by 2.
I got that wrong.
It asked for the morning dose.
Oh, well.
She was probably laughing at my video because I was trying to figure it out in my head, and I kept saying, I need a freaking calculator.
There's everybody. Hi, everybody.
Are we still missing some people?
Rashida and Jenna.
I wonder, will they all pop up on the screen with that many people? Like, will we be able to see everybody?
So everybody will pop up. We have, let's see. This is my puppy.
I see.
I put the other 2 away.
Mm.
Let's see. Who do we have here? Carol.
Hi.
Hi. Dave. Hi, Dave. All right.
Hi, Carol.
Let's see. Dave.
Hey guys, can you hear me?
Yes.
Yep.
Hi everybody.
Hi. Amanda. Okay, Becky. Uh-oh, somebody's sharing their screen again. Jenna, you're sharing your screen.
Yeah, sorry, I'm trying to.
Just so you know.
My computer.
All right, Jenna's good. Shh. Hey. Shh. Aaron's cool. Who are we missing? Is Rashida here?
I heard her, I thought.
I thought so too.
I'm here.
Okay. You're gonna. She's afraid of flashlights, so I got my phone out. I go like this with my phone, and she's afraid of it. All right, I know it sounds terrible. And Becky, is Becky with us? Becky was having technical difficulties.
I didn't see Becky.
No, she said she's having a heck of a time with the Zoom. All right. So, no, she was having trouble with it. So, how's everybody doing?
Good. So far, so good.
Good. So far, so good. Yeah.
Just to remind you guys, I am available. I have office hours. Just email me. We can do our office hours like this. If you don't want to be like looking at me while we're doing them, we can do it by phone. But just send me an email. I have them from 3:30 to 4:30, and I checked, and I haven't heard from anybody yet. But 3:30 to 4:30, and then 7:30 to 8:30. I think I had on there because we're going to do 4:30 to 7:30. So if you need to meet and chat one-on-one, I am available. All of our resources are available for the school. Oh, my husband left his, he has a Apple Watch and he left it here and it's going off. I'm like, what is going off? Let me make sure my phone is off though. My phone off. All right, my phone's on silent. Okay. Our resources are still available for everyone. So whatever resources that you guys utilized before, whether it's ed support, I posted a thing on Canvas today. Ed support from Jeanette. She's willing to meet via Zoom, via phone, whatever, to help anyone with study prep. She has access to Canvas, so she has access to all of your stuff. She has, you know, I was willing, I mean, I can't give it to you, but I'm willing to give her my test with the answer key so she can go over concepts with the students. So she is available for you. Tutoring services available. If anyone needs anything, you know, bigger than that, we have access to several food pantries. Just send me a private message, email me if there's anyone that has any needs like that. Our VP just sent us a big long email. So if there's any issues that are bigger than something that you'd want to talk in the classroom with, please reach out to me. You know, if it's, you know, or reach out to Tina. I know Tina is more than welcoming, and as Ina as well. So do not hesitate to reach out to us, because we do, you know, I think we can get very isolated in this kind of environment. So I'm glad that we're all face to face like this, so that we don't feel so isolated. How's everyone doing with your work lives and your home lives?
Busy.
Yeah,
It's crazy.
I think about you guys.
So far safe.
Okay, I think about you every day. All of my healthcare friends. I mean, not just my healthcare friends, but housekeeping, EMTs, just people that can't work from home. I was just talking to my sister, and she is, you know, does accounting work in Philadelphia, and she was made to stay home, but her husband works in manufacturing, and you can't manufacture something from home. So he's got to go to work. He still has to work. So we're in very strange times. I pray that this resolves as quickly as it has come upon us, and that we, you know, we're fine through it and everything like that. But it's weird. I want to visit my grandchildren, and I can't. I'm just don't want to get them sick. My grandson is immunocompromised, so I don't want to be around him, and so it's very strange. My husband's birthday is on Friday, and we are celebrating it at home. I said, you know, we're not, you know, going out. Although a lot of restaurants are doing like a drive-in, right? Like you can
get it to go, yeah.
Yeah. So I might just do that. I might just, you know, because we're not going out to eat.
You can have a romantic candlelight dinner with wine.
There you go. And the one winery by us in Saylorsburg is talking about doing drive-through pickups for wine.
Sweet.
Nice.
So, I found it interesting. You know, if you look on social media, nobody says a whole lot, you know, about the food being empty. But as soon as they say they're shutting down all the bars and the liquor stores, man, everybody got all in a like, oh my God,
Yeah.
who cares about food? I just want my alcohol. So, but anyway, again, please share anything, any concerns. I like listening. I was kind of taking my dogs out to go pee and run around for a few minutes before we got started, but I like listening to you guys like kind of chattering amongst each other, because you do that when you're in the classroom. So this is a really good environment, and certainly if you miss each other's company, you can create something like this, and you guys can get on and do that. So, all right. Well, I don't have any other questions. I want to make sure everybody is in.
Is Stacy here? I don't see Stacy.
Who?
You might have to scroll down. She was here.
You there,
Yeah,
Stacy?
she's here. She's here.
Okay. Where do you scroll down at?
You should, where it shows the list of all the people, there should be an arrow at the bottom.
I don't even see that list.
On the top.
See anybody else?
I see Dave.
It's the view that you might have too. You can change the view
I did full screen in the top right corner.
Yeah, you can do full screen, or you can do gallery view. We're such a small class here.
All right, I got it now.
Yeah, so
There's Stacy. Hi.
What's gallery view? Oh,
the only thing, or do we have Becky with us?
no.
Okay, let me just check my email and see if she's struggling.
I think things are going to drastically change over the next couple of days because we're going to start getting our results back from the first set of cultures that we took in our office. So I'm assuming that's probably going to be global. So I think things are going to.
That's going to be a game changer, huh?
You guys are doing tests in your office, Mindy?
Yeah, we're doing tests in our office.
Wow.
Well, we were, but now people don't come to our office if they're sick. If they're sick, we're sending them straight for testing. So only people that are well are coming to our office now. However, the person that was positive was in my office, and she was front staff. So our entire front staff is out. So that's frustrating, but we're working through it. They're all healthy. No one has gotten it from her, so they should all be coming back. I don't know. I pray tomorrow, but that's not going to happen. It's 2 weeks, so we just have to hang in there.
What kind of, is it like a throat swab or a nose swab?
It's nasopharyngeal.
Oh,
And it's, go way back, and it has to be 5 seconds. And you have to gown up with the goggles, mask, gown, all that to get the specimen. So we did take a couple specimens in the beginning because we were learning. And then we just started, we call everybody the day before and say, are you sick? Are you having any symptoms? If you are, we send them straight for testing. Docs order the lab right away, and they just go right and get it done. So everything's nice and quick that way. And if they just don't come in if they're sick. That people we're seeing are healthy. We know. I mean, and then we screen them when they get there. We screen them before we bring them back. So we're trying to keep it as safe as we can. It's definitely a struggle.
Yeah, it's tough. I'm thinking of you.
For that Alice training, are we able to access that early, or does that pop up Thursday?
Okay. You should have gotten an email from Barb Morrison about the Alice training. We're changing the Alice training to safety.
No.
Nothing from her.
Okay. Let me write myself a note here. So, because I put that in my notes. I put that on that, like, that information thing. There was a whole bunch of bullet points, and I said, please let me know if you didn't get it, and not one person notified me. So
I didn't see it. There's so many emails.
I know. There really is. I agree. But if nobody tells me, I don't know. So, all right. So I'm just going to say PM, did not receive. I was wondering why I got like a couple emails saying, what are we doing with that? I'm like, well, I thought you got things. So did not receive the directives for Alice training day. Okay, I will find out what's going on with that and make sure you guys get that. I was under the impression, because we're Barb Morrison and Professor Levin said that they told me that they were sending that out to all the students. So I just, it doesn't sound like that was done. So I will, but you guys should have got it through PEDS.
Yeah, you could see the
Did you
I think I did see something about Alice training through the PEDS clinical schedule.
That's the same one.
Yeah.
Yeah, but there was nothing to open up to see what to do.
There was no directions whatsoever.
Oh, okay.
It was supposed to be
I
an
didn't
ATI.
see any.
ATI, you go into, I think it was safety and something else.
I think she has directions in there.
Oh wait, what does it say? Alice training. Hold on, it might be here.
It
looks like it's ATI instructions. It's actually in. Let me.
Can you share your screen?
Where is it?
Mind?
No, I don't mind. Can you see that?
No.
No.
Well, I'm sure.
good. It's underneath, if you go into online clinical modules under PEDS, It's the third one down. It says civility, and then in parentheses, Alice training. It's a document, and it says
Okay.
someone's
I probably missed it because
API.
it says civility. I was looking for
This is the
Alice.
first time I'm seeing it too, definitely. So
How do I see-
Okay, cool.
Yeah, you can show me who's logged on.
I'm trying. Oh,
I was looking in OB because the Dropbox was in OB,
Okay, I see it now.
but the Alice is
right
under
there.
P's.
Okay, click on. Okay, thank you. All right, so I'll just make sure that I remind everybody it's there.
That'd be great.
Okay, so
So I guess our question though is, can we do this early?
yes,
And we don't have to be out of work that day. We can just do it whenever.
yes.
Okay.
As long as you do it before it's due.
Sure.
Correct.
Okay.
Yep, with anything. Michelle Cohen is going to be sending you guys your assignment for Saturday.
And that'll be sent Friday, you said?
Hopefully, she's just working on the answer key. I sent everything to her on Monday. It's a case study, and it's a 12-hour clinical, so it's a little longer than the normal things. But I sent it to her on Monday and asked if she would do the answer key for me. And I think she's going to grade it only because I think she's putting all the work into doing the answer key. I think instead of sending it over to Karen Reisman, she said, you know what, I'm doing all the work. I'm going to know the answers inside out when I'm done. So she's currently working on it. I'll follow up with her when I get off with you guys tonight. I'll follow up with her and see where she's at with this, because I'd really like you guys to get it preferably tomorrow, so that you can have time to work on it. If you're planning on working on Saturday, I don't know what you guys are doing. I mean, I'm not sure. So I'll see if she'll try to get it to you on Thursday. All right. All right. Let's get out of that. All right. I am going to start the lecture. It is being recorded. So when it's done, it takes about a half hour, about 20 minutes, because it downloads as an MP4, and then I take that and I transfer that into a YouTube link. And then I will keep that under module 2, and I'll just date it like with today's date, and I'll just put module 2 PowerPoint 3. But it'll be a YouTube, you're gonna see it as a YouTube link, because by doing it as a YouTube link, it doesn't take up a lot of megabytes under Canvas. And I don't wanna, go past what we're allowed with storage. All right, if nobody else has any questions, I'll have you guys mute your microphones, mute your audio. But don't forget, if you have questions, you can raise your hand. You're going to go down to the participant tab on the bottom. You'll click on participant and then go over to the right where it's lined up, and then just click on raise your hand. But just don't forget, after you raise your hand, and if I've answered your question, to put your hand back down again, because then I'll be like, oh, you have a question again? So we'll get started, but please pause at any time if you have any questions for me, okay? So let me get in here. Whoops. No, I want that. Okay. Do you guys see the screen? You see my PowerPoint? While we're doing this, by all means, have like a notebook or a piece of paper next to it. Because so when I go through, how many usually print out yours? You can just raise your hand if you print out your slides. Okay, so you can just write right next to them. If you didn't, I would recommend like having a piece of paper next to you and just kind of take down notes as I'm saying some additional things and stuff like that. So because I'm not in the classroom with you physically, I love to write on the whiteboard, and I like to do a lot of demonstrations and put you in little groups and do activities. And because I can't really do that, what I decided to do is just kind of put some things that I really want you to, that really stand out. Of course, everything's testable, but things that really I want you to go back to that textbook, revisit, make sure you understand. And I kind of put some things in red that I would normally like do some question and answering or do some activities in the classroom with you with. And maybe I'll try and learn for next week how to do some activities. So we'll see. It's a learning experience for me too. So we're going to do chapter 12 and 13 tonight. And so chapter 12 is based on the postpartum assessment. So there's your learning outcomes and what we're going to be talking about today. And just to show you, like, so when we plan out your clinical, sometimes they seem a little lengthy and a little in detail, because we have to match our outcomes. We have to match what we're giving you with our outcomes. And then we have to report to the State Board of Nursing to basically, so we can maintain our accreditation. So that's why you'll see us doing some of those things. This should look familiar to you. This is that postpartum assessment flow sheet. So how many have had a chance up on the clinical units to go with a nurse or go with one of your adjuncts and do a postpartum assessment, checking fundus, checking vitals, checking mom baby? Has anybody had a chance to? No? All right, well, hopefully, you know, when we go through, hopefully I can give you enough information that it can, you know, it can click, you know. Has anybody had no experience whatsoever with postpartum mother baby, like no experience at all? Raise your hand. I'm not seeing anybody. Okay. So this is what you would kind of use as a guide when you do your postpartum assessment, and it kind of follows like your patient's history. So this would be really good when you're working on your groups, is take your fictitious patient that you're going to be creating your case study for, and just kind of make sure you have a lot of that information, because that's going to cover like your background information. It's going to cover your labs. It's going to look at your past medical history, medications. So this would be a nice little tool to use if you're using a postpartum mom. I mean, you can certainly, I'm trying to think if anybody's doing any women's health. I'm not sure if anybody in this group is. I think somebody, one of my other groups is doing breast cancer or something. So it just kind of goes through everything. Like it has your GTPAL on there. And then next to that, to the right, has whether it's how many postpartum days or post-op days it is. So your post-op day would be your cesarean section. Has any IV, where the IV site is. Then it talks about the infant. It talks about the perineum. Is the perineum intact? Was there an episiotomy done? A laceration? Comes down into the types of births, and then at the right-hand middle column, the bottom, it has like your immunizations. So the MMR was the, when was the MMR, or what's the titer, should I say, of those, or was anything given? And then on the other side of that, it has if the patient is voiding, it has what their rubella status is, because we need to know their rubella status. If they are not immune, when do we give them a rubella, MMR vaccine if they're not immune?
Isn't it after the pregnancy?
Correct. That does cross the placental barrier, so that is not given during pregnancy. And then the other one is your GBS status. And what do we know about if they are GBS positive? What do we know about that? What do you guys want to tell me?
They usually have to have a C-section. If not, they have to get the penicillin. So like twice every 4 hours apart. Right.
So is that Sylvia?
Yeah.
Okay, so that is correct. Now they don't need to have a C-section. They just have to have the antibiotics, the penicillin, at least 2 doses, 4 hours apart. And what can happen if the mom had a precipitous labor, a precipitous delivery, and the baby was born 3 hours or less, and they did not get a chance to get the penicillin into them? What effects could the newborn have from that?
The baby can have respiratory issues.
Correct. And then on the bottom there, it talks about past medical history. So that's where you would include pregnancy history. You could say, any kind of history, in there. And then your labs, and then your medication. So that should look familiar. I'll bring out the cobwebs from you guys. So when you had boot camp, remember going through this with boot camp? And then I would definitely highlight this in your notes. So you want to know your bubble heat. This is really going to, if you have a good understanding of this bubble heat and be able to speak to it, you're going to do really good on a lot of the test questions that deal with postpartum assessment. And then we'll go through the whole thing. So Bubble He is an acronym, and it stands for B is for breast. So whether the mom is breastfeeding or whether the mom is bottle feeding, we want to address this. So what we want to see is we want to see that the breasts are soft, not hard, painful, warm to the touch. So we want to make sure they're soft. They're filling with milk if she's going to be breastfeeding. They may be engorged. Usually you'll see that a day or two into it. And if it's, you know, right after delivery, you're going to see colostrum. You generally won't see breast milk till about 3 to 5 days after she has delivered. But if she's staying, if either she had a C-section or something's warranting her to stay a little longer, then you may see the milk coming in. And so we'll stay on the breastfeeding. What we got here? Here's Rebecca. Hi, Rebecca. So if she is breastfeeding, then we want to assess the nipples. If her nipples are inverted, does anybody know what an inverted nipple means? What it means to have an inverted nipple? So an inverted nipple is kind of, it's inside out. So instead of the nipple sticking out, you know, anteriorly, it's more posterior, or it's more kind of inside. So it's, mom can still breastfeed. There's just some things that she has to work with the lactation consultant and everything to kind of get everything working. Also flat nipples as well. We want to make sure that there's no cracking or bleeding. Make sure that the baby is taking the whole areola and not just on the nipple to feed. Make sure that mom has a good, well-fitting bra. One of the things that she could put on her breasts and our nipple if they start getting a little bit sore is lanolin. Lanolin is safe, you know, for the baby, but they still want to wipe a little bit of that off. And after the baby feeds is kind of air dry, so not to kind of close up the bra, close up her top or whatever, but kind of let that air dry. That's going to help prevent any kind of cracking or bleeding nipples. If she's bottle feeding, the goal is to get that milk to dry up. So no stimulation. If she's taking a hot shower, like don't have a hot shower like right on the front of her, because you don't want anything to stimulate. And just for a couple of days until the milk starts drying out. Have a really well fitted bra, sometimes even a size smaller, just to really make sure that you got kind of get that binder effect. Also, some ice or some ibuprofen if it's really, you know, sore and tender. And another thing they recommend sometimes is cabbage leaves. You can get them right at your grocery store in the produce aisle, and you just put the cabbage leaves inside the bra, and then that's supposed to draw the liquid in and dry out the milk. Then the next part of your Bubble He is uterus. So we want that uterus to be firm. We want the fundus to be midline, not deviated on the right or the left. We want it midline. We want it firm. What would it mean if the fundus was boggy? What would we do, and what could it lead to?
You'd massage it.
Mm-hmm. And a boggy uterus could lead to what?
Hemorrhage.
Hemorrhaging, right? If the uterus, if the fundus was deviated to the right or the left, what could that indicate? Mindy? You had your hand raised.
I'm trying to turn my mute off. I'm sorry. You have them void.
Correct.
Sorry.
Because that's okay. A full bladder can not only distend, or not only it can distend the fundus, it can create it to stay boggy, which would increase her risk for hemorrhaging, and it's gonna deviate. So you make sure that you have her frequently void. Sometimes it's difficult to have them void because if they had, like, say they had general anesthesia or they had a C-section, so they anesthetize them from the waist down, they might not have feeling. So you might need to bladder scan them because they might have some urinary retention. And if they can't void completely, you may need to do a straight cap. So that kind of leads me to my bladder. So I'm at B for breast, U for uterus, B for bladder. And the second B for bladder, you want to, again, make sure that they're frequently emptying their bladder, make sure there's no urinary retention, make sure that they have no complaints of any signs and symptoms of a UTI, such as pain or burning on urination. So you want to measure, especially if they came back from a C-section, you want to measure and keep strict I&O. The next B is bowels. So bowels, you want to make sure that they have bowel sounds before they eat. You want to ask them when they moved their bowels last. You may address if they had a vaginal delivery, they may have hemorrhoids. And so the hemorrhoids and the slowing of the GI tract and everything else going on, maybe some pain meds and stuff like that, that whole thing's going to kind of set them up for constipation. And then constipation, in addition to hemorrhoids, can be very painful. So what would be some interventions as a nurse that we would expect to initiate if they had hemorrhoids and also they have a slowing GI tract, so they're at risk for constipation? Mindy?
Sorry, stool softeners,
Yep, stool softeners.
ambulation.
Ambulation. Jessica?
Don't they have like a hemorrhoid cream to help with the pain and discomfort, like a numbing?
Yes, it's called Tux medicated pads, and you'll see that in the video. Yeah, very good. Mindy, you had your hand raised again?
No.
Oh, okay. So what are some other very basic fundamental things that we teach our patients who are at risk for constipation?
Increased fluid.
Exercise.
Increase fluids, exercise. Jessica?
Fiber?
Fiber? Yep, all those same things still stand. So some of this stuff can be very basic. Any questions on that side? Nope. Amanda's going, nope, move on. Okay, now we're gonna go to our lochia. So the first line there are the types of lochia that you can see. So it's rubra, serosa, and alba. What do you think the color would be in the rubra? Dave, I saw him mouthing it out. Red. Very good. Yep. You were muted, but I could see your lips moving. What about serosa?
Maybe a mix.
Yep.
Pink.
More pinkish. Yep. And then alba?
White.
White, right. So think alba, albino, white. A lot of times you're not going to see the moms anything before the rubra. Usually the serosa is, you're going to see that about 3 to 5 days as well by the time they're going home. And then in addition to the color of the lochia, we want to identify the amount of the lochia. So initially when mom delivers, basically the lochia is getting rid of all of, the body's, it's getting rid of all of the products of conception. So we want to make sure, first of all, everything is coming out, but initially it's going to be heavier. So it's going to have more large amount, and then it's going to go large amount, moderate amount, small, and then scant. Does anybody know how they measure the amounts from large to small?
Is that how much the pad is saturated?
Yeah. So a scant amount would be less than an inch. And it's on another slide as well for you guys. A small amount is less than 3. A moderate would be less than 6. And a large amount would be if they're saturating a pad less than an hour. So if they have, and I have a couple slides in, I'll show you what it looks like. But it'll be the entire pad is saturated in less than an hour. So we want to really keep an eye on that. Then the next one in your bubble heat is your E, and your E stands for episiotomy, but it also can be your incision. So your episiotomy, not everyone. Now, obviously, if they had a C-section, they didn't have an episiotomy. And so your episiotomy, they may or may not have had it, but either an episiotomy or an incision, what are some things we would be looking at? What would we be assessing for? Jessica? Redness.
Swelling?
Approximately.
Infection?
What's that?
Infection?
Infection. So what would be some signs of infection?
redness, swelling, heat, maybe some drainage, purulent if it's infected.
Right, and it might be odorous, right? Foul smelling, odorous. Very good. So that's what we're going to be looking for, and we want to make sure that the edges are approximated, right? And we want to monitor their temperature and everything like that. So give them any pain medications if it's very painful, if the incision's painful, if it's a C-section. We want to have them also do coughing and deep breathing exercises, support the incision. Not a lot of not do a lot of extraneous lifting for the first 6 weeks. There's a thing called a peri bottle or peri care. It looks like, anybody ever home dye your hair?
Mm-hmm.
So you know little squirty bottles. That's kind of what it looks like. And they just put warm water on that, and it kind of cleans the area and stuff like that. And it's very soothing as well. Cold packs can be very helpful. So you want to just really keep that area clean, dry, and just make sure there's no signs of infection. Then the next one is your H, is your Homan sign. And your Homan sign is you're assessing for any signs of DVTs or PEs. In the literature, they're saying that test that we used to do for Homan sign, where we used to have them bring their feet towards their knee, remember, and we asked if they had any pain in their calf. A lot of the literature says that's no longer valid. You'll see a lot of the nurses are still doing it, but really we're just checking the calves for any pain, swelling, redness, any shortness of breath, taking a listen to their lung sounds, keep an eye on their vital signs. So we're just monitor for any signs of for blood clots. And then the next E is the emotional status. So how is mom doing with the baby? Like, if mom had a 36-hour labor, she's gonna be tired, right? So she might say to you as a nurse, can you keep the baby in the nursery for 2 hours? I just want to get a nap. And that she just had a 36-hour labor. Would you think anything about that? She looks really tired. She looks absolutely exhausted having the baby go to the nursery for 2 hours. No. But if every time you come in, she's like, I don't want to see this baby, or really shows no interest in the baby, really shows no interest in herself. The past 3 feedings, she's deferred the baby to the nursery. When you bring the baby in, she has no desire to ask how the baby's doing, how the vital signs are. That would be a concern. So just use your guts. Trust your gut, trust your sense in what's going on there. And then the last one in the bubble heat, it doesn't have it in the E, so just make sure if you're studying, don't forget the P for pain. And the P stands for pain, and you're just assessing mom's pain level. Unfortunately, the opioid crisis has made it very difficult, because we used to say pain is what the patient says it is, right? Mm-hmm. We were all taught. And now patients come in and they say they're in pain, and the back of our minds were like, are they in pain or are they drug seeking? And that's a shame that we've come to that. It really is. But she just pushed out a 7, 8, 9, 10-pound baby out of a very small area. She may have torn, she may have been an episiotomy, she may have been a C-section. So yes, I'm sure she's in pain. So we want to assess her level of pain, medicate appropriately, reassess, that sort of thing. Any questions on the bubble he? So again, I put there up in red and in bold. Just make sure you know this. I would go back and revisit this and just make sure that you can speak to this. Is everybody okay with that? So I gave you guys the link. Do you guys have the link to this video? I'll probably have the quiz. It'll be it's not going to count to a grade, but I'll have a quiz, probably about 10 or 12 questions based on the video. I'll have it set that you can do it twice. I'll have it completely open, so it's not going to be like you have to do it by 9 o'clock tonight or anything like that. I'll just leave it kind of open. It doesn't use Respondus or anything like that. It's just straight up Canvas. And I might put a couple questions just in for my lecture today, just because I'm not there physically with you. So I just want to make sure that everybody has the concepts. So
How do I raise my hand? Sorry.
oh, how do you do it?
Yeah, I can't find it.
At the very bottom, it should say participants.
Okay.
Click on that. And then on the right-hand side where everybody's pictures are, where everybody's video is, scroll next to, like hover over your name, and it should say raise hand.
No. Oh, wait. Yes, I see it now. There, did it raise?
There you go. Now you got it.
Okay.
Do
So
you have-
now I can't see the video. Where's the link for the video?
I sent it to you in an email.
Oh, okay. Thank you.
You're welcome. Would it be easier if I put that on module 2?
Oh, I don't think it matters.
Okay. Module 2 is getting pretty big. There's a lot. I mean, I have no problem putting it wherever you guys want me to put it. Just let me know. But I did send to you, and just email me, Carol, if you're not sure.
Okay. Thank you.
No worries. No worries on that. All right, but I do want to show you this other video. This other video is on a placenta examination. It's really interesting. I'm sure not very many of you have seen a placenta up close and personal. So it's actually a midwife had attended a birth, and she's at the patient's home, and she's going over, she does a great job of going over the placenta. So I'm going to show you that video. So just bear with me here.
So we're going to examine the placenta of this little girl that was born at 8:09, and it's now 10:48 p.m. And what you need as equipment when you're going to do a placenta examination is 2 large Ziploc bags to put the placenta into afterwards, a pair of scissors in case you need to retrim the cord just to look at the blood vessels, some gauze squares sometimes come in handy, and a pair of non-sterile gloves. So this placenta was birthed about an hour and 30 minutes after the birth of the baby. We haven't weighed the baby yet, but it's a good sized baby. And the placenta is usually about the size of a dinner plate. And this baby's cord pulsed for over an hour strongly. So the cord was left alone, nobody cut it. And the baby was able to balance out her blood in the way nature intended. And then after the cord stopped pulsing, we clamped and cut the cord, or the father did. So here, in our first look, we see the bag of waters that the baby was enclosed in. And what I'm going to do is turn this whole thing inside out, so it's the way it was in the womb. So this is the side of the placenta that was closest to the baby. And the membranes were up and around. The membranes go across the surface, the placental surface of the placenta, and then they go right up and around the baby. And so the baby was in here with water, the baby, and the umbilical cord in this little house like this. And it looks like one bag of waters, but the water bag is actually 2 layers. And in this case, the outer layer, or the chorion, is intact like this, and the amnion has shredded and is around the cord. But that amnion inside here was at one time pasted against the chorion, the other bag. So it's actually a 2-layer bag. And so then we look at the insertion of the cord into the placenta, and in this case, the baby, it's very uniform, because the baby has got the umbilical cord inserted into the placenta right in the center, and then the placenta developed around that insertion of the cord. Usually the length of the cord is the same length as the length of the baby, about 19 or 21 inches. This one is a little bit less, so it's just a little bit on the short side. The baby has about 3 inches on her belly button still. But the first thing I'm going to look at with this healthy, rich looking cord is I'm just going to dab the end of it and make sure that I have 3 blood vessels in the cord. Now where that blood dot comes up right away, that's the vein. It's the biggest one. And then there are 2 arteries, 2 smaller arteries that you can see creating little dots. I don't know if you can get up close. And I think I'm going to just recut it so we get a clean view of this. Just take a little bit off. When the father cuts the cord, or the partner cuts the cord, it's quite rubbery, and you really have to almost work to get through it because it's really rubbery. That's a jelly inside the cord called Wharton's jelly, and I'm just going to pat that again so we can clearly see those 3 vessels coming up like little red dots. What is the jelly made? The jelly is called Wharton's jelly after Dr. Wharton, and it's just protective of these 3 vessels. So what you have here is at the top, you have the 2 arteries, and then the vein is this bigger one down below. And when I squeeze it a bit, you get blood coming through those. So in the baby before it's born, the arteries actually carry the deoxygenated blood, and the vein carries the oxygenated blood to the baby. And then when the baby starts to breathe through its lungs, there's a shunt in the heart that closes off and shunts the blood the opposite way for the rest of our lives. Now I'm going to turn everything over and look at the side that was closest to the mother. So we call this the maternal side, and you can see there are some clots on here. This is not placenta, this is just clot material from the mother where the mother was stopping bleeding. This baby was born right on her due date. The placenta is good and heavy, like that's probably a lot of what the mother felt when she felt the weight of the baby.
Good.
Yeah, and it's a little bit calcified. It's got some calcified deposits on it. When I rub it, it feels almost a little bit like sandpaper. Those are not significant whatsoever. It's just some people, they get a little bit of calcium on the maternal side of the placenta. And the thing that we look at is the placenta complete? And you can see if I hold it like that, it looks like there might be a piece missing there. So what we do is we cup it the way it would be in her body against the mother's womb. And then you can see it all fits together nicely like a jigsaw puzzle. I've been attending home births for 35 years, and I've never seen a piece of retained placenta because we do wait for the placenta, and the placenta comes out naturally. So it always comes out complete like this. So that's a healthy placenta that nourished a well-grown baby. And the baby grew inside that beautiful sac. Beauty. Okay, good. So then you can just...
All right. Any questions about that? Any thoughts? Pretty interesting. Just looking to see what nobody's hands up. Okay. There we go. All right, so these are the adaptations that occur. So do you remember when I was teaching about the changes that occurred when a mom became pregnant and how she had an increase in blood volume and how all those changes were occurring to all of her systems? So now the mom delivered her baby, and it's probably poor Rebecca. No, it's for she. Yeah, okay. And so she delivered the baby, and now her body needs to go back to what's known as her pre-pregnancy state. So the blood pressure should return back to what it was before. The pulse rate may be a little lower than what it was in labor, because think about that. Remember that she had like a 40 to 50% increase in blood volume. That's going to drive the pulse rate up a little bit. So now her pulse rate should drop back down. It might be a little tacky at first, especially because she loses between 300 to 500 milliliters of blood. So she might be a little bit hypovolemic. Her uterine fundus, really important, highlight this, and I go into another slide about this. Her fundus should go down about 1 centimeter or 1 finger breadth per day. So when the baby is born, her fundus is at about the level of her umbilicus. And then each day, it should go down about 1 finger breadth or 1 centimeter below. So in a normal non-pregnant woman, do you think we could feel her fundus? Do you think we could feel her uterus? No, we shouldn't. It's going to be going back down into the pelvic cavity. So it takes about 4 to 6 weeks for it to completely go back to its pre-pregnant state, which is known as involution. So you'll hear that term involution, I-N-V-O-L-U-T-I-O-N, involution. And I have it on another slide for you as well. But that basically means that the mother's body is going back to its pre-pregnancy state. Then we talked about the lochia. So the lochia is going to go from very bright red to very white or alba. And the bladder should not be palpable unless it's distended, unless it's, unless she's having urinary retention. We should not, it should be non-palpable. Her perineum should be smooth, pink, without any edema or bruising. And her emotional state, it's going to vary. I mean, she just had all those hormones. The hormones are kind of in a state of flux, but for the most part, she should have a stable emotional state. She may be crying, she may be sad, times sleepy and stuff like that, but we want to really be able to differentiate between, is she having normal postpartum feelings, or is she having postpartum depression or postpartum psychosis? So we just want to kind of watch for that. Any questions so far? Everybody's good? Okay. So take a look at that woman there. And if you assess the fundus and it's deviated to the right or to the left, what does that mean?
Just a full bladder usually.
Yeah. So if you see that it's deviated, and it's a little hard to tell, but that is deviated a little bit to the right there in that picture from her midline, then she has a full bladder, and just have her void, and that should. And then you wouldn't want to go in. Another thing, when you go to do your assessment, you wouldn't want to go and start feeling the fundus without offering her to void first, right? That wouldn't be very comfortable. So here is what I was talking about. Remember I said every day her uterus will start going back down to its pre-pregnancy state. So when she first has the baby, where do you think her fundus would be? What letter when she first has the baby?
Would it be B?
Correct. Right. So it would be right at the level of the umbilicus. And then it's going to slowly start going down every day, about 1 finger breadth or 1 centimeter. So do you see how it's there at B, and then it starts coming down 1, 2, 3, and so forth? So about, what's that?
So after 9 days, it should be normal again? Is that what that's saying?
It's starting to go, that's a little exaggerated, but yes, it should be, yeah, it definitely should be. That's about a little over a week. It won't go to its complete pre-pregnancy state till about 5 weeks, but it should not be palpable after a good week and a half. Changes in the fundal position. So a boggy fundus increases the risk for hemorrhaging. Your mom is at highest risk for infection, hemorrhage within the first 24 hours. So you're going to be strictly checking her vital signs, checking her fundus, keeping an eye on her labs, taking a look how does she look and stuff like that, and really keeping an eye out for any signs of hemorrhage. So what would be some other signs we would notice with her if we think that she is hemorrhaging? I think of signs of hypovolemia. Jessica?
Would her blood pressure drop?
Yep. Yep, her blood pressure would drop. What else? What would her heart rate do?
It would go up.
Yep, heart rate would go up. She may look paler. You might even see it in her oral mucosa, a little paler looking.
Respirations would go up too, maybe.
Yep, her respirations will go up. What about labs?
Hemoglobin would be down, maybe.
Yeah. Yep. So we're just kind of keeping an eye on everything and making sure that she is not hemorrhaging. A little more about assessing the uterine fundus. So when you watch the video, pay particular attention to how to assess it. The nurse, when she does the video is a little bit antiquated. The concepts are amazing. The concepts are still what I'm teaching. One of the things that they do in the video is they give the mom, I think either oxytocin or pitocin by just pushing the medication into a bag of lactated ringers or normal saline, which we don't do no more. We would have it already pre-done. So, but the concepts of doing a postpartum assessment are spot on to what I'm teaching. So I do like it for that. So what they're doing in order to assess the uterine fundus is they're placing one hand on the lower segment of the uterus, usually around the symphysis pubis, and then using the side of the other hand, and they're doing that until they can palpate into the abdomen so they can locate the top of the fundus. And it takes a little bit of time to get used to doing that. So that's what they're doing. And then they're determining, obviously, is it firm or is it boggy? And if it's firm, they're leaving it alone. And if it's boggy, then they're massaging it. So if you go in and you assess your mom and she has a boggy uterus, the first thing you would do would be massage it, right? Now, say you massage that uterus and it's still boggy, and you feel really confident in that you massaged it and everything. What would be what would be another step? What would be another nursing intervention or an intervention? It's a medication. Go ahead, Jenna.
I was going to say, would you ever void, but that's if it's deviated.
Yeah, so yeah. Who said that?
Carol.
Yep, so methergine, oxytocin, pitocin, any of your uterotonics. Remember our uterotonic medications? So any of those would, their role of the uterotonics is to contract that uterus. So any of those uterotonic medications would be your next line of treatment. Okay, oops. Let me go back to that slide there. What else I want to tell you about that? Oh, and yeah, I think everything else we covered. We talked about the, measuring the fundus in finger breaths, and we talked about midline, and we talked about lochia. So what are the key things about the lochia again we'd be looking for?
The color?
The color. And what would we expect initially after she delivered?
Rubra.
Very good. And Mindy, what else would we be looking for? Or Jessica?
Would you check to see if there's a lot of clots and make sure she's not filling more than a pad an hour?
Correct. So you want to see the amount. So we want to see initially it would be large, and then it should start getting, it should decrease. Very good. just a sample of documentation. If you were going to assess your mom, you would just, you're assessing her fundus. I just kind of gave you a little nursing note there that, you noted that her fundus was either midline or deviated. You notice her fundus was in what location in relation to the umbilicus, whether it's at the umbilicus, 1 finger breadth above or 1 finger breadth below. And then is it firm or is it boggy, and addressing the bladder, and did she void and stuff. So that just be like a sample assessment finding that I just kind of put in there for you. Any questions at all on any of that? Oh, just want to tell you, if you lose me, a little thing just came up, told me my internet is unstable. So if for whatever reason I disappear, I will try to log back in, and if it continued and I couldn't get back in, I'll let you guys know. But this morning I had no problem. I think one of the orientations I had problems. All right, the next thing we're going to talk about is the perineum, and I think we covered pretty much everything there. I'm trying to see if there's anything different. Any questions on that? So it's pretty much what we talked about, looking for swelling, edema. If there's any lacerations, you want to assess, for signs of infection, and, give her some ice, and let her know that it'll heal in 2 to 3 weeks. Is everybody okay with that? All right. It's 5:30. How are you guys doing? Do you need a break at all? No? Okay, just let me know. You won't hurt my feelings if you say, you know what, you need a break. Also, if you have to just get up and go to the restroom or address something, don't feel like you're trapped here and not allowed to do that. My morning class, I think 2 of my students had their children there. They just kept their thing on silent because a lot of people have their children at home, and different people are in the home and stuff like that. So, this is life, right? we do. Oh, I think this is Rebecca again. Oh, poor thing. I feel so bad. I don't know why her internet keeps kicking around. I'm sorry, Rebecca, you're having trouble, but this is being recorded the whole time. So anything you missed, you can definitely go back to the recording. Lochia, I think everything we've covered. Let's take a look at that last bullet point. And if you see a reverse of the lochia, so say the lochia is starting to get scant, and then all of a sudden it goes to moderate, that's a problem. So it should not reverse. If it does, that's a sign of hemorrhaging. So just keep an eye on that. And also on the second to last bullet point, any increase in exertion and breastfeeding, sometimes you'll see that she'll have a little bit of an increase in lochia, or the first time she stands up, she might get a big gush. And then, so there's what it looks like. Make sure you know this. So there is your scan amount, which has less than 1 inch. And then your light amount is less than 4 inches. And then your moderate is less than 6. And then your heavy it's saturated within 1 hour. So you can kind of really see the difference there between the 4. Any questions on that one? Jenna's like, no, carry on. All right, what should you report? This is kind of common sense. Any high or low blood pressures? It has low blood pressure, but you can add on there high blood pressure as well. Because what can the mom be at risk for after delivery that she was at risk for when she was pregnant?
Preeclampsia.
Correct. So any hypertension you would report as well. Tachycardia, which would be a sign of hemorrhaging. Any uterine atony or very boggy uterus, excessive bleeding, or an increase in temperature. Let's see, we talked about this. So that colostrum is basically, that baby's first food, and it has a lot of antibodies. And then it'll transition into mature milk. My dog is being a real pain in the butt right now. If you see me going like this, it's because I'm like swatting at my dog, like knock it off. I'll show her the flashlight. Flashlight. I don't know why she's afraid of a flashlight, but she is. All right, so that's what the milk looks like. So if you look at number 1, that is your colostrum. So it's like a beigeish, yellowish color. And then as the milk, as the milk starts to come in, about 3 to 5 days, you'll have 2 kinds. You have your fore milk and your hind milk. Anybody know the difference between the fore milk and the hind milk? So the fore milk is the milk that first comes in when the baby starts nursing. And a lot of times moms will nurse, the baby will fall asleep. I don't know if you ever heard of that. The baby nurses for about 5 or 10 minutes and is sound asleep and they can't get the baby to wake up. And then they're complaining that the baby's feeding like every hour and the mom's like ready to lose her stuff there because like every hour the baby just, falls asleep in 5 minutes and then is wake again another hour screaming to be fed again. And what happens is the baby's not latched on long enough or staying awake long enough to get that hind milk. And the hind milk is the milk that has higher calories and it's going to increase the baby's satiety or its fullness. So the difference between the two is that the fore milk is the milk that comes out right away, and the hind milk is what's going to be more higher in calories to help the baby to be more full and get all the calories from that. So it's going to be higher in carbohydrates. And then on the far right, oh yes, Jessica.
When you start nursing, how long does it take normally for the hind milk to start?
Usually about, in initial stages, probably about that 8 or, like the first 5 minutes will be the fore milk. So they're probably like your 5 to 10 minutes. We'll start getting the hind milk, but it might not be set until like you have breastfeeding kind of established. So that's why a lot of times those babies are feeding constantly. Or they're falling asleep. So probably like more closer to your 10 minutes. That's why they usually say at least feed for 10 minutes on each side. Carol?
So every time you breastfeed, it starts out with that, or does that stop after a while?
No, it will start out with that, but the baby will get more efficient at nursing and really be able to suckle much stronger as they get more efficient in nursing and they're able to get it. But initially when they're neonates, they're not real efficient at it.
Okay.
Anybody else have any questions? On the far right side, you see, and then you also see on the left side that different things can change the color of the milk. Medications and blood are not good. Sometimes some food can change the color of it and maybe even the taste of it. If they see a dark red like that one on the upper right to the left, that would be a concern that maybe there's some blood in the milk ducts and that needs to be reported. Before we go on to the other slide, I think I have it on there, but maybe I'll ask you guys first. Do you think of some reasons why breastfeeding would be contraindicated? Why would there be times when we would tell the mom that she cannot breastfeed and she needs to bottle feed?
Breast cancer?
Yep. Good. Who was that? That Carol again?
No, Jess.
Jess. Yep. Breast cancer.
I only know sometimes if the baby doesn't latch.
Right. So if they're having a lot of trouble and very frustrating, yep. And somebody else just had their hand up. Then it went away.
I have my hand up.
Okay, go ahead.
I would say medications mom's on that the baby can't breastfeed.
Right. So if they're on certain psychotropic meds, HIV meds, certain medications that cross and go through the milk and go to the baby. Let me see. Who else had their hand up?
Carol.
Carol, go ahead.
Like if they're on illegal drugs like marijuana, stuff like that.
Absolutely. Yep. So if mom has an opioid addiction, a drug addiction, alcohol goes through. Jessica, go ahead.
If they have a blocked duct?
They have a blocked duct, yes and no. Once they get that blocked duct cleared, then they should be able to.
So just, I mean, like just temporarily.
Temporarily,
They
yes.
would be able to, yeah.
Yep. Yep. I don't know if we mentioned it. We did say cancer, so if they're actively on chemotherapy, and think about anybody who has any kind of breast surgery or breast augmentation, either they had, like they got implants, or they had a mastectomy and they just had a really good surgeon who was able to do reconstructive surgery. Go ahead, Mindy.
What about a breast infection from breastfeeding?
Yeah.
Yeah,
Yep.
Treat it.
Yep. Absolutely. Very good. Great answers, guys. Anybody have any questions? Good job. Other things, I think we talked about this, inspect for engorgement, which would be, the engorgement would be the breast would be very hard to touch, not soft, and maybe red, very painful. And an easy way for that is warm. Remember I told you, like when we don't want them to breastfeed, to be careful of those hot showers. If they're really engorged, a hot shower is actually very beneficial. Warm compresses would be really good. And assessing for any signs of irritation or breakdown in the nipple. And any plugged milk ducts, so that the milk is there but it's just not coming out, and that actually can lead to an infection. So you want to really make sure they address those and educate the mom about that. There was something about plugged milk ducts, and I put in my notes to tell the other students, because I had here box 12.3, and I think I was looking at my other my older book, but let me see. If I can't find it, I'm going to put it on the announcements or something for you for that. But there was something I wanted to talk about there. Oh, here we go. 374. Let's see what it says here. So write down on your notes, page 374. Let me see what I have on there. Okay, so there's that box 12.3. So the box 12.3 is on page 374. I'm going to make a note of that. So if you just write that in your notes, page 374. I guess I just want you guys to kind of take a look at that. It talks about some breast care and assessment. So it looks at like engorgement, what to do, treatment for breastfeeding women, prevention and treatment for non-breastfeeding. Okay, and then plugged milk ducts are associated with inadequate emptying of the breasts. And symptoms could be palpation of tender breast lumps. And then the treatment would be frequent feedings, changing the infant feeding positions, warm compresses, massaging, warm shower, continue to try to get that milk, continued blockage can lead to mastitis and breast abscesses. So you want to really make sure to teach the moms about that. But just go back, I would go back to that box 12.3 on page 374. It goes over a lot of little more little tips and stuff when you're doing your studying. Any questions? All right, and then we talked about this a little bit about that breastfeeding woman or non-lactating woman. So making sure that she has a really well-supported, well-fitting bra, sometimes a size smaller to be kind of tight. Avoid any breast stimulation. She can put on some cool compresses, like 15 minutes on, about 45 minutes off. And then I put a little picture down there of those cabbage leaves. There's really obviously no cabbage bra, but she would, you can get those right in the produce aisle, and you just put those cabbage leaves inside the bra. And the idea, it's actually a homeopathic therapy. And it's supposed to dry up the milk. If she's having a lot of discomfort, she can take some mild analgesics. Any questions with the non-lactating woman? We talked about this, so reasons not to breastfeed. I think you guys covered everything. Just trying to see. Nope, you guys did good. So definitely go back and revisit that. But you guys kind of all talked about that, and just be really respectful and mindful of the woman's decision. We don't always know what their story is, and so we just want to be respectful of that. Any questions, or does anybody want to add anything, or have any thoughts on this? No? Okay. Cardiovascular system, we talked about the mom loses about 200 to 500 milliliters of blood after delivering, so she's at risk for orthostatic hypotension. So what are some of the real key fundamental things we're going to do if she has orthostatic hypotension? Jessica?
Make sure she's sitting down. We don't want her to fall.
Mm-hmm. So have her get up slowly. Maybe sit at the edge of the bed, especially the first time she gets up. Have her sit at the edge, and picture maybe she's on some, had some pain medications too. So just kind of dangle her feet and stuff like that. So just the first time that she gets up out of the bed to go to the bathroom, you want to be present with her and walk with her until you feel like she's comfortable. We don't want anybody falling. She can have some transient anemia, which should resolve in about 8 weeks after the delivery. And I bolded this for you. I put this in red, that her white blood cells may be increased. Initially, she may have an increase in temperature and an increase in white blood cells, which would normally, 30,000 blood cells would look elevated to us, right? But in the postpartum mom, initially for like the first week, that might be normal just because of all the changes and everything that has occurred during the stress of labor and during the delivery. And we also know that she has an increased risk for blood clots. So you want to really be monitoring for blood clots and any PEs. So this is just basically the pattern of taking her vital signs afterwards. So what does it remind you of? Every 15 minutes for the first hour, every 30 minutes for the second hour.
Post-op.
Yep, that's your general post-op. So same thing, you're going to be checking her vitals frequently until stable, or as per hospital policy. But obviously, if they're not stable, you're not going to, if her vitals are all over the place, even after the first 24 hours, we're going to be taking them more frequently. Also, if they're on magnesium, you're going to be if they're on mag, it's every hour, or at least at Lehigh Valley was every hour. I'm not sure where St. Luke's is with that. Does anybody know? I don't know if you guys went to Luke's for that. Should be afebrile except for the first 24 hours. Remember, I told you due to exertion and also the dehydration. We talked about orthostatic hypotension, rising, rise slowly. Respiratory system. So the rest, she'll have an easier time breathing now. She doesn't have that growing baby up against her diaphragm anymore, so she'll have an easier time breathing. But if you want to watch if maybe she is on mag, we want to keep an eye on her respirations. Blood volumes, you want to just, we had our baseline, so we just want to keep an eye on everything and make sure everything's going back to baseline. And do you guys have this slide? Okay, so and these are just your I have your labs on Canvas on their documents, but just I put your normal PT results there and your INR, and kind of said don't forget about your labs. There's always going to be questions about your labs. So I'll give you a second to write that slide. Are you guys doing okay? Anybody need a break? Let's see who's on with us.
Where it says know your labs, do we need to copy that?
No,
Basically the PTIR?
yeah, well, you have all your labs.
Yeah.
That was just a screen. That was just like a little image that I put in there. They did that, but I would definitely know your H&H though.
Okay,
But you know definitely know your stuff.
okay.
But that's just an image. Any questions? All right, so let me just go over the immune system. Just the two areas I want to cover is your mom's rubella status and your mom's RH status. So which one of those, if she's not immune, are we going to hold off and give after she delivers? Jessica?
The rubella.
Right. Because the
And you don't
rubella,
want to get pregnant for 2 months after.
you
as
got
well.
it. You got it. Because the rubella can cross the placental barrier, whereas your RH, if mom is RH negative, when did she first get RhoGAM? If she's RH negative, how many weeks? Anybody remember?
Is it 26 maybe?
Yeah, close, Carol. 28.
28?
Yep. So 28 weeks, and then how about after delivery? Does anybody remember just how many hours after delivery?
72?
Yep. Yep.
And then you also, for an amniocentesis, you get it.
Correct. You just read my mind. I was going to say, what are some other instances where she would get a RhoGAM shot if she's RH negative? So after an amniocentesis, what else?
Do we not have this slide?
Oh, you don't have this slide?
Sorry, it's right in front of my face.
Oh, okay. I'm like, oh no. All right. So what else? What would be some other situations where if the mom is RH negative that she would get RhoGAM, other than amniocentesis? Good, Jessica.
If she has a fall or an injury, gets in a car accident.
Right. So anytime that blood has that the maternal and the fetal blood can mix. All right. So just make sure you differentiate between those two. Urinary tract. I think you guys are good on this. Everybody okay with that? We're just checking to make sure that she doesn't have isn't having any urinary retention, making sure that she's not, she's emptying her bladder completely, watching for any signs of UTIs, hematuria, and understand that certain medications like anesthesia can make it difficult for her to sense that she has the void. So we might have to, straight catheter, or she may have the cath in and we're monitoring it. That's pretty much what that's about. Does anybody have any questions on that? GI tract, you want to make sure that she has bowel sounds. We don't want to be having her eat anything, especially if she's a C-section, and we don't want her to develop an ileus. So we want to make sure they have bowel sounds. And you want to make sure that if she's breastfeeding, she has a lot of fluid. So because as soon as she starts breastfeeding, especially when the milk comes in, she's going to be very thirsty. So you want to make sure that she's drinking a lot of fluids, good fluids, water. I don't know what they're, decaffeinated. I was going to say decaffeinated teas and stuff like that. After pains are basically contractions. They're the contractions that are occurring after she delivers because the uterus is going back into its pre-pregnancy state. And we want the mom to have that. We want that uterus to be contracting because that's going to prevent her from hemorrhaging. Every time the mom has a baby, the after pains are stronger. That first time mom, that nulliparous mom, her after pains or her contractions aren't going to be as strong. So some different things you can do is, give her some medications, especially if they're breastfeeding. When they breastfeed, the uterus contracts. So maybe kind of plan ahead prior to, say, hey, you know what, she's having a hard time with the after pains. And I think if you tense up, the milk's not going to release. So you say, okay, I'm good. Let me know when you're going to be nursing the baby again, and I'll come in about a half hour beforehand and give you a little ibuprofen or something for pain. Also, a lot of times moms are on some type of oxytocin or Pitocin postpartum to prevent hemorrhage, and that also causes those contractions as well. Follow-up care, you're following up to make sure, make sure she has her appointment scheduled for about 4 to 6 weeks. You want to talk about postpartum depression screening. So that should be done before she's discharged, and then follow up with on the outpatient end if there's any concerns. Talk about her plans for contraception. So, spacing of the, of pregnancies, and if there's any vaccinations that she needs to get at this point, coming up with a plan for that. Discharge things that you would need to be reporting is definitely make sure she reports any signs of any fever, infection, increase in bleeding, any signs of UTIs or frequent or burning on urination. And then the two big ones, any signs of preeclampsia, such as your blurred vision, headaches, epigastric pain, fluid retention, which would be your HELP syndrome, any leg pain, swelling, or chest pain, which would be DVT or PE. So you want to really make sure that mom understands those and knows when to call and when to be seen if she's having any problems. Any questions on the postpartum assessment? That kind of concludes our postpartum assessment. How do you guys feel about that? There we go. Anybody have any questions? Everybody good?
Yep, good.
Okay. All right, now we're going to talk about contraception. And let me give you the page number of the chart in your book that goes over that. So it's actually starts on page 384 and it goes to page 387. My old textbook that I used to use prior to using this Davis, each of the contraceptives, were talked about were a different, like some of them were like a page and a half on each one of these. You're not expected to be able to tell me every single contraceptive out there. What are the side effects? What are they for? What type are they? Et cetera, et cetera, et cetera. So the new book, I really like it. It kind of breaks it down into your groups. And I'm going to give you what I want you to know from these. So I'm going to kind of give you the highlighted versions as we go through. So these are your 5 different methods. So you have your natural methods, your barrier methods, your hormonal, your long-acting reversible, and your sterilization. So the first thing, let's take a look at those and think about those. What is an example of a natural method? Mindy?
Abstinence.
Absolutely. Absolutely. If it's not happening, it's not going to happen, right? Very good. What about a barrier method?
Condom?
Yep. Hormonal?
Birth control.
Yep. So the pill. Long-acting reversible contraceptives. Yes.
IUD?
Yep. Your IUDs, or they call them now IUCs, or the implants that go in the arm. And then sterilization. So sterilization for a man. Carol? Oh, you're muted, Carol. There you go.
Vasectomy,
Yep, vasectomy. And then for a female?
tubal ligation,
You got it. So out of all of those things we talked about, what do you think would have the lowest failure rate?
barrier.
Okay, that's low, but what?
Wait, the lowest failure rate?
Sterilization.
Yeah, sterilization.
Even lower than that. Sylvia? You're muted.
Abstinence.
Abstinence. Very good. Very good. So abstinence, when you get a chance, take a look at your textbook. If you have it there on 384, if you look at abstinence, abstinence has a failure rate of 0 because it's not happening. Now, abstinence is under your natural methods. One of the natural methods is known as coitus interruptus, or also as the withdrawal method. And for those of us, if we remember back to our A&P, the whole process of sexual intercourse, there's sperm on the tip of the penis even before penetration. So the withdrawal method is at a 22% failure rate because they can still get pregnant. That's a lot of teens don't realize that that is 22% is. So in addition to the abstinence being 0, what do you think would be, I think somebody already said it, what do you think would be next to that?
Sterilization.
Right. And then sterilization, I'll just go back to and I'll not expect you to memorize these, but just have an understanding of which ones have the higher and which ones have the lower. I'm not going to ask you for the numbers, okay? Because I don't even know them unless I go and look. So sterilization, the vasectomy is 0.15, and the tubal ligation is 0.5. So pretty much snip, making it go away, is a pretty, good bet as well. All right, so let's talk about these in individuals now. So our natural includes, we talked about abstinence, natural family planning. So natural family planning is, remember we talked about infertility and we talked about taking the body temperature every single day and looking to see when the temperature would rise, then the woman is ovulating, right? So they can use that in either way. If they're trying to get pregnant and they notice that pattern where the temperature rises, they know that they're ovulating, and they're trying to get pregnant, like, come on, we need to do this. We want to have a baby, right? And then if they're using the natural family planning method not to get pregnant, and when they're at that ovulation period, they're like, nope, store's closed right now. Nothing's happening. We don't want to get pregnant. Okay, so that's what that means. Coitus interruptus we talked about. Another one that sometimes women, when women are breastfeeding, a lot of times, not always, but a lot of times when they're breastfeeding, they have no period. So they think, I don't have a period, I'm breastfeeding, I don't have to worry about getting pregnant. And let me look and see what that percentage was. They don't have it on there. They don't have the percentage for that, but just let the mom know they can get pregnant when they're breastfeeding. Just because they don't have a period, they can still be ovulating. It's decreased, but there's those fertile myrtles out there. So just saying. Any questions on the natural methods? Okay. And that's a picture of that basal body temperature method I was talking about there. You see the rise in the body temperature about midway after the red line. And then you see that it decreases again. So barrier method, I think you guys already kind of said. So some of your examples of your barrier method, I kind of highlighted them in red at the bottom. So you have your condoms, and just so you know, I'm sure you do, you're adult men and women. There are male and female condoms. Vaginal sponges, caps, diaphragms, and your gels and stuff are also part of the barrier method. But the one that's really going to protect you against STIs is which one?
Condoms.
Condoms, yep. Your other ones, your caps, your diaphragms, they are not there. If you're using it to as a contraceptive, it's going to work. But if you're using it as a method of protection from STIs, it's not going to. So they would still need to have a second form of protection. Does that make sense? That's if you don't know what a condom is. I don't know anybody who doesn't, but just in case, there it is. That is what the vaginal sponge looks like. And that is what a cervical cap looks like. The cervical cap is individually fitted. So it's an individual fit because we're not a one size fits all women. So you want to make sure that you have a good fit because you want to make sure that none of those little sperms are getting up there and impregnating you if you don't want to be impregnated. The thing with the cervical caps and also the diaphragms, which need to be fitted, both of those, the one downfall to them is they both need to be left in place for 6 hours, which can be a real, who wants to do that? And with the diaphragms, it increases the risk of UTIs and yeast infections because you're thinking you're leaving that in there. And I believe with the diaphragm, also increase the risk of toxic shock. So both the cervical cap and the diaphragm must be fitted and must stay in for 6 hours. So if you want to put, highlight those things. But both of them must be fitted by a healthcare provider. Both of them must be left in place for 6 hours. So my thought on those is think about the women who use those as a form of contraception and then say, I don't understand why I got pregnant on this. My question would be, how compliant were they with leaving it in for 6 hours? So I think sometimes people say some of these forms of contraception don't work, but I question how compliant they are with taking everything. So, in certain instances, there's a compliance part to it. Kind of just like the pill. If they're missing it or they skip, they miss 2 days and now they're trying to double up, whatever, it's not going to be as effective. Spermicide is over the counter and that can be used with other barrier methods, but again, it's not effective against STIs. All right, so our next type we're going to talk about is your hormonal, and we're going to talk about the 2 different types of hormonal. We'll talk about the progesterone and estrogen, and then the progesterone only. Comes in a couple of different forms. I think the one most people are familiar with, or at least my generation was familiar with, was the pill. They now have injectable, such as your Depo, or your implants. They have vaginal rings, and they also have the skin patches as well. And it can be combination, so you can have a combination of estrogen and progesterone, or a progesterone only. So which do you think of a woman is lactating, had a baby and they're breastfeeding or lactating, which one would be safer, do you think, to use? A combination of the estrogen and progesterone or the progesterone only? Or you're not sure?
Would it be progesterone only?
Correct. It is. It is progesterone only. And we're going to talk about those. So your combination, your estrogen and your progesterone has a very low failure rate of 9%. Again, don't get hung up on the failure rates. I'm not going to test you on the failure rates, but I will test you on concepts about which has a higher failure rate versus which one has a lower failure rate, and we discussed that. The pills also don't protect against STI, so if they're having multiple partners and their concern is getting an STI, is to use a condom. And then on this last bullet point, I'd highlight this, or if you're taking notes, I would make sure you write this down. So the contraindications to the estrogen and the progesterone using any of the hormonals is your big ticket items are your history of any clotting disorders. So also having a history of a DVT or a PE, history of high blood pressure, age greater than 35, history of smoking, history of active cancer, especially your estrogen dependent cancers or your reproductive cancers as well, like your ovarian and your breast cancer. And I said clotting disorder. So they're your big things that you would be teaching someone who is looking to go on to an estrogen, progesterone, or going on to the pill. taking a look at their history, their past medical history, and their age, and putting these things into perspective, and possibly offering them a different option, which we'll talk about. Do you remember when the nurses came on our on-campus clinical and talked about this? The same nurses came and talked about the Plan B. So the Plan B, the big thing that the Plan B was designed for was in rape cases and sexual assault. It needs to be used within 72 to 120 hours of the incident. It's also can be used in the instance of contraceptive failure, such as a broken condom. And it's not to be used as a regular form of contraception. So it's not one that, someone's going to be getting a prescription for Plan B once a month. It's considered your emergency hormone therapy, hormone contraception, should I say. Any questions so far on all the different types we were talking about? And are you guys doing okay time-wise? Does anybody need a break? Everybody okay? Thumbs up? Everybody all right? Okay. Just let me know.
Yep.
You're good?
Yeah, I'm good.
Okay. All right. So now we're going to talk about your progesterone only. If you want to highlight these, your progesterone only can be used during lactation. So an example would be, they also call the mini pill. So you may hear the mini pill being used, and that's a progesterone only. The progesterone only has a higher failure rate versus the combination because it doesn't have any estrogen. And there is an example, your Depo-Provera. It's an injectable every 3 months. How many have heard of the Depo shot? Okay. So the woman goes to the doctor. She actually probably doesn't even need to see the GYN. She'll probably just have a nurse visit. And what do you think they would check prior to giving the Depo shot?
See if they're pregnant?
Correct. So they would do a pregnancy test to make sure that she is not pregnant, but it can be used during lactation. One of my students brought up a question about the use of oral contraceptives during pregnancy. And, because sometimes there's a failure rate on them. They didn't use them right, but they're still using them. And I am going to look that up on ACOG. The only thing I can think of is there's certain things out there that actually could induce a spontaneous abortion. So I will get some information. The student had asked me, so I'll share that with everybody. That was one of the questions they asked me in the morning class today. So the Depo can be used during lactation, and that's an example there of the Depo shot. Go ahead. Who had a question?
Jenna.
Go ahead.
Why would somebody use the progesterone as only, like other than just for
Lactation?
Yeah, would they use it? Is that the only thing, just lactation?
Well, no, if they have some of those contraindications as well.
Oh, okay.
So they, it doesn't have the estrogen in there.
Okay, so estrogen is against all those contraindications. Okay.
Yeah. So if they have like an estrogen dependent, history of cancer, different things, it might be safer for them.
Okay, that makes sense.
The patch is just, when you think of a patch, when you apply a patch, think of everything you know about putting on any type of a medication patch. You want to make sure that site's clean and dry, and you want to rotate the sites to decrease any irritation to the skin. It's applied, the new patch applied the same day of the week, each week for 3 weeks in a row. And I highlighted this in red. I'm not sure if it shows up on your slides. If not, the 4th bullet point, really important point to mention about the patch is because it goes through the dermal layer, through the skin layer. It's very sensitive to a person's weight or their BMI. So it's more effective if a woman weighs less than 198 pounds. Whereas if a woman has a higher BMI, it is not as effective because of having to go through the layers of skin of the skin and through the layers of fat. So that's one little tidbit of information that you'd want to know about the topical patches. And a lot of these ones also you probably have heard or read, you know, mood changes, because they are hormones. So mood changes. Some women complain of weight gain with a lot of your hormonal contraceptives. Any questions so far? Vaginal ring. That's a picture of your vaginal ring, and that is not that the woman inserts that herself. It's a hormone-filled ring, and it's left in for 3 weeks and then removed for 1 week, or it can be left in for 28 days and then a new ring inserted. Personally, my opinion is I wouldn't want something in me for 28 days, or something like that. But everybody has to use what works best for them. So we are fortunate that there's a lot of options, you know, for different women for whatever works for them. And this is just a more intense list of the contraindications. So we obviously pregnancy, you wouldn't be using contraception if you're pregnant, but there may be that off chance that you got pregnant while on contraception, maybe because the person wasn't compliant with it. And then any clotting disorders, any cancers, especially your estrogen-dependent cancers, smoking, high blood pressure, diabetes, hyperlipidemia. So they all kind of fall under the same, not that they fall under the same category, but they are your, you know, like generally speaking, if someone has diabetes, there's a lot of times that they may have hypertension and hyperlipidemia. And then, and again, any clotting disorders. But I'm fine with what I gave you in my other slide. I gave you those, like, I think 6 different things. That would be something like NCLEX would ask you those big ones: smoking, clotting disorders, history of cancers, high blood pressure, that sort of thing. Any questions? Is everybody good with this slide? Jessica, you good? Okay, our next one are our long-acting reversibles. So I want to say Jessica said it, the IUDs or the IUCs. So we'll go into those. The first one is the injectable progesterone only, and that is given about every 11 to 13 weeks. The next one will be your intrauterine contraception, which is known as your IUCs, which used to be IUDs. So IUCs and IUDs, if you want to put those in your notes, are kind of, for testing purposes, I'll use the term IUC, but I would spell it out anyway. Very low failure rate, 0.2. And they use copper ones that can be used as emergency contraception, which can be inserted within 7 days of intercourse. So that's gives you a little more leeway. I'm trying to remember if Amanda, the same nurses, did they talk about this as an emergency contraceptive after those 72 to 120 hours? Do you guys remember? I can't remember because I had to step away. Because I was getting ready to get those med math tests. Does anybody remember if they said anything about that?
I don't think they did. I didn't know that this could be used for emergency.
Yeah, I didn't think they mentioned it either. I'll have to ask them if they want to include that next year on the slides. And this is an example of it, but this is magnified. So don't freak out if you've never seen one and you're considering one. This is very large. It's magnified so that you can see what it looks like. Obviously, it's much smaller inside the woman. Does anybody know anybody that uses IUCs or have any thoughts on them? No? Okay. I hear good and I hear advantages and disadvantages. I hear some people absolutely love them and have really good success with them. And then I've heard other people say that they've kind of traveled and they've gone to different areas. They've caused, ectopic pregnancies and stuff like that. So I've heard varying stories with these. All right, the next one, how about the hormone implants? Have you guys heard about these? They go into the arm. you can't see them, but you actually could feel them when they implant them, and that can last for several years. It's done in the office as an office procedure, and they can breastfeed with these as well. So these can be used during lactation. And then our last one, which holds next to abstinence, which holds one of your lower failure rates, is your sterilization. And we talked about that in the very beginning. So you have your vasectomy. And just to kind of let you know like what exactly they're doing, I kind of highlighted that in red. So basically they're surgically severing that pathway for the sperm. And then the other one is a tubal ligation, and it's actually a surgical procedure as well under general anesthesia. And they used to have 3 types. It used to be they would clamp it, they would tie it, or they would, like, for lack of better words, like cauterize it. And from what I'm understanding, they're really going more with the cauterization because they were finding that the tubes become untied very easily, or they would or the clamp would come undone if you take it. Like there's a couple of videos out there. See if I can find them that shows you the procedure, and when you see it, you can see how easily they can come undone because they can be reversed. You do have to tell your patients if they are choosing to either reverse the vasectomy or reverse the tubal, that there's a high chance that they might not be able to get pregnant. And then there's also that chance of those, I'm sure you guys have heard stories of people who all of a sudden had a oops moment. All of a sudden they untied or unclamped or came back, fixed themselves, and all of a sudden, down the road, here comes a baby, because they thought that they had a vasectomy or a tubal done, and here comes this baby, shows up when they're like in their mid-40s, and like, no. Any questions on, we talked about postpartum assessment and we talked about contraception. You guys good? All right, this next one is really short. I'm just going to give you the skinny on the transition, because really what I want you to know, there's just a couple of key points that I want you to talk about, and then we'll go over some questions. So we should be pretty good. We're definitely not going to run till 7:30. Probably about another 20 minutes, 20, 30 minutes. Are you guys okay? I don't want to lose you. Am I losing anybody?
No, I'm good.
All right. Okay, so what I want you to know on this slide, this is what's known as the maternal phases. So when the woman has the baby, and they actually describe it nicely in that video that I want you guys to watch, that postpartum assessment video. So when the woman has the baby, she goes through these stages from taken in to letting go. And basically what the taken in means is she's kind of more focused initially on her physical or her personal comfort and the physical changes. And it doesn't really last long. And then she transitions to that taken hold phase. And that's just as it says, to take and hold. And that's where her focus shifts from her to that baby. And then the letting go phase, that's where it's just as it says, she's letting go of all those preconceived notions, all those thoughts and fantasies about what everything is, and she's just rolling with it. She's getting accustomed to her new role as a mom, as a mother, as a wife, and learning her new normal. So for anybody who has children, when a new child comes into your life, no matter how it is, whether you adopt it or you have one of your own or you marry someone and you join families, you now have a new normal, right? So that's kind of what that letting go phase is. She's kind of, moving on and taking in her role. Does that make sense? That's really kind of the gist of what that is saying. I mean, when you're studying, you can certainly go through and read all the different things. And there's another slide, a couple slides in, that talks about like the nurse's role. And really one of the key things is what we're looking for also is that she is transitioning well. If she's not transitioning well, what's going on? Is she having some postpartum depression, or is she having some, or even worse yet, postpartum psychosis? So what is going on that she's not transitioning to that new role? This talks about bonding, kind of talks about the same thing. You want to be seeing that mom bonding with her baby. Is she enjoying her infant, or is she pushing the baby away? And I'll give you an example. So like the mom has like a 36-hour labor and she's exhausted, right? So would you think anything of it if you go in, you see mom's absolutely exhausted. She pushed, for a long time. Maybe they wound up doing a C-section after all, whatever. And she just looks drained. And you come in and she's been doing really good at trying to breastfeed. And then you come in for this check on her and she just says, can you just take the baby to the nursery so I can just get some sleep? Would you be concerned about that? No, because she just had this really long, intense labor and she is exhausted. Now, on the other end, every time you go in there, every time you see her, she's, hitting the call bell saying, can you just take this baby? Can you just take this baby? Can you just take this baby? And you're seeing this pattern of her not wanting this baby. Then would you be a little more concerned? She's constantly like you see that she's really not focusing on the baby. She's, really doesn't seem like, a lot of times when you bring that baby in, the first thing is like, they're like, give me that, let me have my baby now, right? Or they're asking, how's the baby's temperature? How was the baby's assessment? Or if they came back and had immunization, did the baby do okay? And if you're not seeing that, that's a concern. So that's kind of what that's all saying. This slide, what I want you to get out of this slide with family dynamics is some different ways to help that sibling get adjusted to that new baby. So what are some things that you guys could think of that would help, especially that young 3 or 4-year-old who really doesn't understand yet? What are some things that can help? Carol?
I actually had a question from the last slide.
Oh, I'm sorry.
It's okay. So say you are concerned about bonding or attachment. What do you do?
Then you would definitely, hopefully at that point they had done the that postpartum depression assessment. Maybe that might give you a little bit of insight. And at that point, that is something you want to mention to the physician. You want to mention to the case manager and get some resources and ask. That's when you would ask those. You would sit down and have that conversation with mom. And as much as and we'll talk about it more when we talk about postpartum psychosis. But you could ask. Come straight out, like in the hospital setting, we wouldn't expect that, but you could say, do you have any thoughts of harming yourself? Do you have any thoughts of harming the baby? Is there anything going on that you want to talk to me about? So you sit down and have those conversations with her and make, the other members of your team aware of your concerns and make sure that she's not discharged before these concerns are addressed.
Okay, thank you.
Good question. Good question. All right. And then Jessica, you were going to answer my other question about what are some things that you could tell the new mom, the pregnant mom, what she could do.
I would say have the child maybe help decorate the baby's room, like include them in preparation, like don't leave them out with anything.
Good.
And introduce them to the baby when the baby's born, maybe with help, let them hold the baby with the parent beside them.
Very good. Very good. So just that's really what that was saying. Another thing you can do, especially if they're little, if they're like 3 or 4, you could have, like, the mom could pack a wrapped present in her hospital suitcase. And then when they come to visit, they could say, that you have to do it for a younger one because an older one would know, would be able to figure it out. But, a younger one, you can say, oh, look what your baby sister or baby brother bought for you. And if they're little enough, they'll buy it, right? If they're older, they're not going to go for that. But, it's the different things. Have them listen, have them go to one of the appointments, listen to the first time you hear the heartbeat, those kind of things. Anybody else want to add anything to that? And that's just another, I should have put that slide with the transition slide. This is the one I was telling you about that kind of gives you some nursing actions on what to do and some different things to do with family dynamics. All right, how you doing? That's the end of everything. I'm just going to go over some NCLEX questions with you guys and talk about what we're going to talk about next week and call it a night. All right, so this question here, number one, the nurse is determining a post. Oh, Jessica, yes. Are you good? You're muted.
I was going to answer the question.
Go ahead, Jessica. What's the answer?
2.
How about you guys? You guys agree? Or you want to look at it yet? Mindy saying yes. Sylvia saying yes.
Yes.
All right. You guys are too fast for me. And this is the third day I'm presenting the same material. So I'm getting a little, wah! All right. Number 2, during a postpartum assessment, this one's going to have 2 answers. The nurse suspects a full bladder. Where is the fundus located for the nurse to make this determination? Jessica?
A and C.
A and C, yep. And you guys can type in too. You can, in that chat, there's a chat feature. You can type in also. This question, think about this one a little bit. The clinic nurse reviews the lab results below for a postpartum patient who's 3 days delivery. What should the nurse do in response to the results? So take a look at the results, and then your options are document the findings, assess the client for increased lochia, assess the client's temperature, or notify the healthcare provider. So think back to some of this information I gave you on on the changes that are occurring postpartumly with the mom.
Would it be 2?
What gives you her lochia? What's her H&H? 37 and 11.
I meant 1.
1. Anybody agree? What? And that's correct. What made you think that? What was your rationale? I agree. You're correct.
Because the lab values are normal, and you said the white blood cells would go up to 30 for a few days after delivery.
Correct. You got it. Bingo. All right, the next one. Don't mind how the font looks. I was doing cutting and pasting, I think. The laboring client, and this takes back to your lecture 2 weeks ago, is in the first stage of labor. She's talking and laughing with her husband. The nurse should conclude that the client's in what phase? A, transition, B, active, C, active pushing, or D, latent. Carol? Oh, you're muted. You have to unmute. There.
Latent.
Latent, very good. The nurse is caring for this was the same one. There you go. The nurse is caring for the client in labor. Which assessment finding would help the nurse determine whether the client is in the 3rd stage of labor? So think what's happening in the 3rd stage of labor from 2 weeks ago. Your answers are lengthening of the cord, 1, increased bloody show, 2, a strong urge to push, 3, or more frequent contractions, 4. Carol?
Number 1?
Correct. Very good. Jessica? Are you going to answer that too?
Yep, I'm good.
Okay. The laboring client is experiencing dyspnea, diaphoresis, tachycardia, and hypotension while lying on her back. Which intervention should the nurse implement immediately? 1, turn the client on her left side. 2, turn the client on her right side. 3, notify the attending obstetrician, or 4, apply oxygen. Mindy.
Number 1, turn the client on the left side.
Correct. Jessica, was that what you were going to say also? Okay. You guys are a bunch of smarty pants. Very good. So remember, this goes back to, I think we talked about this in one of the first lectures. So when the client is lying supine, it can block or occlude the inferior vena cava. So by turning her on the side, it's going to take the pressure off and increase perfusion. Mindy, do you have a question? Oh, you just have your hand up still. All right, that was everything. So I just gave you here's some other resources to kind of use in conjunction with my notes. So obviously, definitely review your textbook and expand on any content in your textbook. Kind of like I was telling you, some of those page numbers. Use your CLGs. I think I'd have to look at the study guide, but there's a couple of CLGs on the study guide that will be testable material for exam 2. Look at your ATI books. Look at your ATI. I always say, another good idea is to use content out on the web. Look at exam questions that have nothing to do with your ATI or your Davis. It still has the same content, but maybe it's asked a different way, because that kind of helps to see if you understand the concepts. So if you can just like go out into the World Wide Web, so to speak, find questions that are related to postpartum assessment or contraception and stuff like that. And if you can answer those questions, providing that they're on the same concepts as us, then it tells you that you're getting the concepts. I gave you Nurse Labs there. I gave you a link for that. Davis, do you guys know that you have you can access Davis questions online from your textbook? So utilize those, and don't forget about fundamentals and med-surg and the stuff that's kind of being brought into that. Any questions on there? And then this is what we're going to address next week. So we'll be talking about postpartum hemorrhage, which we started to address today. We're going to talk about postpartum depression, respiratory distress syndrome with the newborn assessment. And then next week's lecture will be your last lecture for the content for exam 2. All right. Do you guys like this format? I just want to put it out there. If, I don't want anyone getting sick. I don't want anything happening, or you have something extraneous. Just communicate with me. Say, you know what, I'm not going to be able to make it today. This is what's going on. I'm going to take a look at, I do take attendance, but I will take a look at things case by case. Just privately reach out to me in an email. But I want to keep structure. I want to keep consistent with you guys. And I think it helps versus just reading the PowerPoints on your own. I try to give you a little more insight to it. Carol.
Are we going this route for the rest of the semester?
That is correct. Yes, the school is completely online, 100% for the whole, actually it's probably going to go into the summer.
Okay.
We're being told, but definitely this whole entire semester, 100% online at this point.
Okay, thank you.
The school's closed now. You guys know that, right? The school's closed. Okay. Mindy?
I just kind of feel like there's like a lot of content for this second exam. Any suggestions? I know you have a study guide posted, but any suggestions on how to kind of get narrowed down, or kind of needs to be?
What I would do is look at the stuff that I really like. When I did activities, like you saw, like last week, I really honed, like 2 weeks ago, I lied. 2 weeks ago, I really honed in on, I really made it a point to go over the fetal heart rate and your decelerations. And I really tried to, say, make sure you so when I do activities and stuff, I really am honing in on those things. I think I really want to make sure you guys knew the stages of labor and what was kind of going on, like how far dilated and effaced she was. So I would go over the key things. Yeah, it is a lot of content, but I would go over those key things that I talked about. I tried to really say, make sure you know this, make sure you highlight this. I always try to give those little tidbits. If you catch me, if you hear me, I usually will say, you want to make sure you know this. You want to make sure you go back to that chapter, page 374, and look at that box. They're my little hints that I try to help you with. And Mindy, if you want to meet with me one-on-one, if there's some areas that you just want to revisit, and anybody, not just Mindy, I mean, Sylvia, Ivana, Carol, Dave is, let me find Dave. Let me actually stop sharing here so I can see everybody. Where Where is Dave? There he is. Okay, so any of you guys, if you want to meet one-on-one, just reach out to me. I have no problem with that. I'm kind of stuck here. So, you know, they're telling us not to, you know, be socially, oh gosh, what is it? Distant, socially distant or something like that. You know, I'm quarantined. I'm sorry. I go out as little as possible. They closed the school on me. My friends don't want to be around me. So, but reach out to me, guys. Really, use me as your resource. We're all in it together. We're here for you. So, any other questions?
I do have one more question.
Yes.
When we're watching the video, watching the whole process, is there a way to make you bigger? Because you're kind of, I don't know, on the side you're kind of small. I was just curious if there's a way to make you bigger.
When you're watching my recorded video on the YouTube, if you do full screen, it doesn't get bigger.
You're just you're the same size as everybody else.
But when I record it, when this is done, it's going to go into an MP3, which is you'll see it after you look at it. I think you'll be fine with it. And I'm going to put it into a YouTube format so that you can expand it.
Were you on gallery view or speaker view?
Right now?
I mean, if she's seeing you small, she might be on gallery view because speaker view, you show up big.
Oh, speaker view. I was not on, I don't think I was on
Full
speaker view.
screen.
Yeah, if you click at the top, it'll say gallery view or speaker view.
Well, when she's doing the presentation though?
Yeah.
Okay.
Oh, when I was doing the presentation, I minimized myself because I wanted you to see the PowerPoint.
Okay.
But you were able to see the PowerPoint, right?
Oh yeah.
Okay. Yeah. That's why I when I'm doing the PowerPoint, my focus, I wanted to be on what I'm doing. Does that help? Does that make sense? I can feel your attention through the screen. She's smiling. No, I know you got a lot going on. I know you do. Anybody else? I'm going to change to gallery view so I can see all of you. Anybody else have any questions, concerns? Anybody want me to stay on? Okay. You know that I have office hours. We can meet one-on-one. All of you. Dave, you got that? Rashida, I can't see you, but I know you're there.
Yeah, I'm here.
Your name's there.
I'm here. I'm here.
Oh, I know you're there. That's why I said I don't see your picture. All right, guys. I will see you next Wednesday. And this is okay? You guys like this? You don't want you?
Yeah, I like it a lot. I like
Okay.
it a lot.
All right, I'll see you next Wednesday then. Oh, hi, kitty cat.
See you guys later.
What a cute cat. All right, see you guys later. Bye.
Bye.
Bye, guys.
Bye.
Bye.
Bye.